When we perform clinical analysis on whole blood for a complete blood count, one of the things that we are looking for is anemia. Now, anemia in itself is not a disease, but rather an indication of a patient's overall wellness. A lot of the types of anemia that we find in patients can be traced back to a core cause. And we really want to treat the cause of the anemia so that we can provide the patient with better overall health. So, what exactly is anemia? How do we define it? Well, a general definition of anemia is a decrease in the blood's ability to carry oxygen to tissues, resulting in hypoxia. Now, that could mean that there's a decreased number of red cells. It could mean that the cells are dysfunctional for one reason or another. And there could be several causes of those types of conditions, but without the proper amount of hemoglobin, whether it's quantitatively or qualitatively, a patient is not able to oxygenate tissues appropriately. The complete blood count, or the CBC, is the most commonly used lab test that indicates if a patient is anemic. CBCs are typically run on an automated instrument. Now, this is an example of our setup. We now have so each one of these are Sysmex hematology analyzers. There is a automated track that runs across the front of them. Now, this setup isn't exactly like the setup we have here at St. Luke's. It looks like the one we used to have, but we have since updated it. So we have a newer version. But this would be the slide maker that automatically makes the slides for us. We now have Cell-O-Vision, which would be an addition to this, and a newer updated slide maker. But this is the general idea of what a setup would look like. And again, I have already shown you kind of the anatomy of a CBC. We've got our white blood cell, our red blood cell, hemoglobin, hematocrit, and then our red blood cell indices. We then have our platelet count and our platelet volume. This next half is a portion that is in pink that is labeled diff. Really is the portion of the CBC and differential that we're looking at with regard to the white blood cell populations that are present. So we have neutrophils, lymphocytes, monocytes, eosinophils, basophils, immature granulocytes, and our nucleated red blood cells, which are put underneath the differential because they can sometimes be mistaken by our automated system for red or for white blood cells. So we have to visualize them and quantitate them. And then of course we have our reticulocyte portion, which counts our reticulocytes. And then if we can also do a body fluid differential and cell count on our automated instrument, which is going to give us results here in this purple box. Now, if we have any flags, if you see any IP messages under white blood cell, red blood cell, or platelet, we're going to stop and we need to manually review our CBC. At that point, we would look at the morphology. We would count and differentiate the types of white blood cells and how many there are. We would count 100 white cells and then put that number as a percentage. In addition to that, we would look at red blood cell morphology and inclusions and platelet morphology. So we would have white, red, and platelet morphology. And we haven't really talked about white morphology or platelet morphology, but we are going to talk a little bit about that when we get into our anemias, especially our macrocytic or megaloblastic anemias. But yes, this is what our general CBC looks like. And we will get more in detail about these different scattergrams and the different parameters in which we're looking at when you get to the second half of your, when you get to your senior year, when you're on your bench rotations. We will do a methodology course on hematology analysis. So you'll see lots of things there, and you'll learn how to interpret this, and you'll understand and learn the methodologies of the varying types of methods that we use, including flow cytometry, fluorescence, and impedance. So again, there are multiple causes of anemia. First and foremost, it could be a blood loss, acute blood loss, could be a slow blood loss that is a chronic, for example, like a GI bleed where a person is losing little by little, could be heavy menstruation. Maybe there's an increased destruction of red blood cells, so maybe an hemolytic anemia, so some type of hemolysis is occurring. There may be a nutritional deficiency, such as an iron, B12, or folate deficiency. And remember, all of those things are important. We not only have to be able to signal the bone marrow to produce new red blood cells when they're needed, but we also have to have the building blocks in which to do so. And when we have nutritional deficiencies, our body doesn't have the building blocks available to build new cells as needed. Infection can cause anemia, and there may be some acquired or hereditary defects. There may be also some chronic diseases, such as chronic kidney failure, that can lead to anemia, and we call those anemia of chronic diseases. So in that case, something like a depletion of hematopoiesis, because the kidneys are not able to pick up that, to sense that hypoxia and trigger the bone marrow to make more red cells because they can't function well enough to produce that that erythropoietin for hematopoiesis. Sorry guys, can't speak English today apparently. So sometimes a patient will come into the doctor's office and just have some very non-specific symptoms, clinical symptoms that could be associated with anemia. So some of the clinical signs and symptoms of anemia are fatigue and weakness, dyspnea, which is shortness of breath, nausea, constipation, or diarrhea, melena, which is basically dark, bloody stools. They may not look bloody, they might actually look black and tarry, and that depends on if there's a GI bleed and where it's at in the GI tract. But all these symptoms are very nonspecific, making diagnosis very difficult without laboratory testing. Now, our job is to provide clinical or medical analysis so that a physician can take the data that we provide based on our analysis and correlate it with the clinical signs and symptoms. And that is really how diagnosis is made. They don't just take lab results and say, well, yep, that's it. They consider the clinical signs and symptoms to decide what type of testing should be performed to either prove or disprove their suspicions. Okay, now I really want to go into a little more detail about those red blood cell indices that we talked about a little earlier when we were talking about red blood cell morphology, etc. So the red blood cell indices that we have are going to be first and foremost hemoglobin. Next we have hematocrit. Then we have MCV, we have MCH, we have MCHC, and then we have the RDW. Now, these red blood cell indices can help us to determine the cause of anemia and to monitor the treatment. Let's take a look at hemoglobin. Hemoglobin is going to be the first indicator that anemia is present. We've already talked extensively about hemoglobin, but we know that it's an intracellular red blood cell protein complex that's responsible for the transport of oxygen and carbon dioxide between the lungs and the body tissues, right? So if we have a decrease in hemoglobin, that means we also have a decreased capability of transporting oxygen and carbon dioxide. If you think about that, that could explain why shortness of breath is a symptom, why weakness is a symptom of anemia. Now, we've kind of already briefly gone over this, but in order to understand what we're looking at when we perform analysis, we must be able to recognize the normal from the abnormal. So knowing normal ranges is vital to being a good analyst. Our normal ranges for hemoglobin in males is 13 to 17 grams per deciliter of blood. So that's actually just a measurement of how much hemoglobin should be present. And for females, 12 to 15 grams per deciliter. So those are the normal ranges. Now, if we are to see anything below 13 for males or 12 for females, that could be an indicator that this person is becoming anemic. And if we see a very elevated hemoglobin, that could be a sign that number one, either the patient is very, very dehydrated, or two, they may have some type of metabolic disorder such as hemochromatosis. Our next red blood cell index is hematocrit. Hematocrit is essentially the packed red cell volume, or in other words, what percentage of your blood volume is just actually cells. So we have a fluid portion and we have a cellular portion. And the hematocrit is measured, say for example, if we were to spin down a tube of whole blood, this top layer here is considered to be the plasma. And all of this dark cellular material here, that would be considered the hematocrit. And if you look here, this is about 50%, maybe a little bit less than 50%. And so this would represent a normal hematocrit visually. So normal ranges for males for hematocrit is 40 to 50%. So this about matches a normal hematocrit. And for females, 36 to 45%. Now there's something interesting. If you were to look at a normal patient with a normal red blood cell count and a normal hemoglobin and a normal hematocrit, what we would find is something called the rule of three. This rule of three is as follows. We would take the red blood cell count times 3, that would equal the hemoglobin, and then the hemoglobin times 3 would equal the hematocrit. And it's a formula that holds true, but only when you have normal-sized cells. So no hypochromic or macrocytic or microcytic cells. You really need to have a normocytic size. So your MCV would have to be between 80 and 100 femtoliters for that to work. I know we've already talked about the MCV in one of our earlier lectures, but let's talk about it again. So the MCV, or the mean cell volume or mean corpuscle volume, is the average size of individual red blood cells in measurements of femtoliters. Microcytic cells fall with an MCV volume of less than 80 femtoliters, and these cells appear small. So you can see them in comparison to this small lymphocyte, small normal lymphocyte. They should be about the same size, and clearly most of these are much smaller. So this patient would have microcytic red blood cells, meaning small cells. Excuse me. A normocytic red blood cell or red blood cell population would be within the normal range of MCV between 80 and 100 femtoliters. And again, these cells look more normal size. They have that nice central pallor, lots of color. They're just looking great. And then we have macrocytic red cells. of greater than 100 femtoliters. And of course, these cells appear much larger. Now, this patient has a variety of different cells sizes, but you can see these larger cells where the arrows are pointing. Those would be representative of macrocytic cell populations. Our MCV is actually it's a calculated value, which we are going to talk about how to calculate that here shortly. This next red blood cell index, the MCH, or the mean cell hemoglobin, is the average weight of hemoglobin in each red blood cell in picograms. So our instrument has taken and calculated the average weight of hemoglobin inside each red blood cell. And remember, that is a very, very tiny measurement. A picogram is only 10 to the negative 12th of a gram, so 1/1000th of a gram. That's a very, very tiny measurement. The normal range for MCH is 27 to 34 picograms. Now, don't get confused between your MCH and your MCHC. Your MCHC is bean cell hemoglobin concentration. So that is essentially the average concentration of hemoglobin in 1 deciliter of red blood cells, or basically how much color is in each of the red blood cells as a cumulative measurement. So MCHC units are measured in grams per deciliter, so weight per volume. I know I did mention this in earlier lectures, but we can classify anemias with two red blood cell indices, our MCV, which is size, and our MCHC, which is color. So MCV represents the size of the cells, and MCHC represents the color. With a low MCHC, less than 32 grams per deciliter, the cells appear pale with a very large central pallor. You may have clinical disorders that include iron deficiency anemia. So we're going to have decreased hemoglobin production due to lack of resources, aka iron. We don't have enough iron to make hemoglobin. And then we may have a thalassemia, which is impaired hemoglobin production. And that would be due to a quantitative disorder of those globin chains, and it might be alpha or it might be beta, depending on the type of thalassemia. For normochromic, so a normal MCHC would be somewhere between the range of 32 and 36 grams per deciliter, and these cells appear normal with color and have a normal area of central pallor. Now, ordinarily, you think, okay, well, what if it's greater than 36? Wouldn't that be hyperchromic? No. Physiologically, because of the way in which the red cells are created, they have a physiological limit on how much they can contain without rupturing. So there's really nothing that is physiologically possible than being greater than 36.5 or 37. If our instrument reads an MCHC of greater than 37 grams per deciliter, we know that that is artifact. Something external is causing an interference with our instrument's ability to read the MCHC, and so therefore we would have to investigate the cause of that. But physiologically, there is no such thing as hyperchromic. We can have hypochromic or we can have normochromic, but not hyperchromic. So we may have a microcytic hypochromic anemia, which means our MCV is less than 80 and our MCHC is below 32. We might have a macrocytic normochromic, which means that the MCV is greater than 100, but our MCHC is between 32 and 36. So there are lots of different lots of different types. We could have a normocytic, normochromic, which we do see very often in certain types of anemia, especially anemia of chronic disease. And in that case, we would have a normal MCV of 80 to 100 and a normal MCHC of 32 to 36 grams per deciliter. So that is the starting point of how we classify anemias when they are found. Not to sound redundant, but I am going to repeat myself several times when I talk about MCHC. Hyperchromic cells do not exist. The term hyperchromia does not exist. MCHC can be up to 37, but again, higher is physiologically impossible. And if there is a higher value given to us through our automated analyzer, it could be because of lipemia, which means basically very heavy amount of lipids circulating in that blood sample, or cold agglutinin. And cold agglutinin could be an autoimmune disorder. It could be basically those red cells are sticking together. They're not going to be separate cells. So the test is, there's some interference with the test methodology and it can't be reported accurately. The exception to the rule is spherocytes. Remember, spherocytes lack that spectrin that caused that biconcave disc shape. So you just have those round water balloon type cells, and they do have a physiological MCHC of 37. However, they are very, very susceptible to rupture. So that's the downside of that. The final red blood cell index that I want to introduce you to today is called the RDW. That just means red cell distribution width. And this is essentially a measurement of the size variation of the red cells. So a normal range for RDW is less than 14.5%. So that means very little variation between the size of the red blood cells that are in circulation. And a higher RDW means there's a lot of variation, so greater than 14.5%. When we have a high variation of red blood cell size, we call that anisocytosis. So there's a very specific term that helps us, that lets us communicate with other scientists and with physicians that there is a large degree of variation. So in this picture on the left, we have pretty normal looking cells. Everything is, it looks pretty consistent throughout. We don't have a lot of variety. And then over here we have some little tiny cells. We've got some big fat cells. We have everything in between. Very, very varied. Lots of variation here. What we should see normally is like this bell-shaped curve. We might have a little variation, but for the most part, everything should fall within here. And when we have an RDW that's very high, it means that we have a disproportionate amount on either side of what would be considered normal. All right, important formulas to know. So our MCV, our MCH, and our MCHC are all calculated values. Our instrument takes a variety of components and does a calculation, and let's talk about that. So the way that we could calculate our MCV value is we are going to take the patient's hematocrit times 10 divided by the red blood cell. The MCH is calculated the hemoglobin times 10 divided by the red blood cell. So MCV is hematocrit based, MCH is hemoglobin based, and then our MCHC takes both the hemoglobin and the hematocrit into consideration. We've got hemoglobin times 100 times or divided by the hematocrit. Now, I always remember these two are the same. They have 3 letters, and that is going to be with multiplied by 10, and this has 1 extra. So that is going to be the higher multiple there. That's how I remember that when I was a student. I don't know if that helps at all, but I know it did. You just have to find those little things that you can help yourself remember. You will need to know how to calculate these for both your exam and your boards. For your red blood cell unit and your board exam will definitely need you to be able to extrapolate this information. For example, if I were to ask you to classify an anemia based on size and color, you would have to be able to calculate the MCV. If I only gave you the red blood cell count, the hematocrit, and the hemoglobin, you would easily be able to determine what the MCV was and what the MCHC was, and you would be able to tell me if it was a microcytic or a normocytic or a macrocytic anemia, and whether it was hypochromic or normochromic. So you don't always aren't going to have the MCV and the MCHC given to you, but you can always calculate it. Oh yes, reticulocytes. How I love reticulocytes. They are a good sign of health. Essentially, again, reticulocytes are immature red blood cells that are anucleated, so they have already lost their nucleus, but they do have a little residual RNA, and they appear as polychromasia. Now, this picture that I've shown you here, again, is stained with a new methylene blue stain. It can be visualized with the new methylene blue, and sometimes you will hear special stains or new methylene blue stains considered a supravital stain. We can see the polychromasia with just the usual right stain, but we can't see the actual RNA aggregates present without that new methylene blue. Okay, so with right stain, it appears that's polychromasia. With the new methylene blue, we can actually see these RNA aggregates that are apparent in the picture, and that can be definitively counted as a reticulocyte. So again, when we have these reticulocytes in circulation, they are immature cells and they can be seen as polychromatophilic red cells on a right stained smear. Now, I just want to make a point. Right stain does include new methylene blue, but it also has eosin included. And we're going to talk more about the characteristics of the stain components when we get to the white blood cell unit, because the properties of the stain components actually stain different white blood cells based on their net charges or their affinity for each of the different types of stains. So we'll talk more about that later. But just for now, know that on the right smear stain, it appears as polychromasia. And on the new methylene blue or the supravital stain, you can see the aggregated RNA very visibly. This is a really good representation of what we see when we have very prominent polychromasia. So here we can see those kind of more violet colored or bluish colored cells. They are polychromatophilic reticulocytes. But when do we see polychromasia? Well, we see polychromasia in hemolytic anemias, such as sickle cell anemia, because they have a rapid turnover of red cells. They have a higher instance of red cell destruction because of their abnormalities, and therefore the bone marrow is really trying to compensate by pumping out more red blood cells to replace the ones that were destroyed, and sometimes they come out a little bit immature and in reticulocyte form. We see polychromasia very prominently in neonatal patients, newborns, And that's because they no longer have their mom to rely on, and their bone marrow is adjusting to the outside world. They now have to breathe air and transport oxygen outside of the womb. And so their bone marrow becomes much more active than it was prior to birth. And then, of course, recovery from acute hemorrhage. Whenever we have a massive blood loss, we are going to see a very high reticulocyte, assuming that we have the resources to make those red cells quickly, because our body is trying to protect us from hypoxia. So we've already talked about the RDW with regard to it being a red blood cell index. And we know that when the RDW is greater than 14.5, we consider that to be anisocytosis, or what we consider anisocytosis to be present, rather. This anisocytosis is an indication of a large variation in red blood cell size. We can get a reading, we can get an RDW analysis on our CBC automated printout, and we can look and visualize the size or the variation of size on the scope. Okay. Now, there's another term that I'd like to share with you, and it is regarding the patient's variation in red blood cells shape. So let's move on to the next slide. So the term poikilocytosis is a tricky term. It just means a large variation in red blood cell shape. And unfortunately, we don't get a printout value for poikilocytosis. This is something that the instrument can't tell us. We have to actually look at the red cell morphology and visualize it. So when you see, say for example, this patient has some spherocytes, they've got some schistocytes, they've got some Burr cells, they have acanthocytes, they've got a mess going on. This is a disaster here. And then this patient has some ovalocytes, they have some target cells, they've got some microcytic red cells over here. And in this picture, this is a cartoon. We've got some sickle cells. We've got, it looks like this patient might have some sickle cells too. But we've got ovalocytes, teardrops. So we've got a large variation in the red blood cell morphology shape. And unfortunately, our instrument, again, cannot give us a value on that. So we have to really visualize it and manually review the red blood cell morphology so that we can accurately report it. So we did talk a little bit about the different morphology shapes that we might come across. Probably the more important, I wouldn't necessarily say the more important, but the most common types of morphology that we see in poikilocytosis are ovalocytes, sickle cells, target cells, schistocytes, and spherocytes. Those are the ones that we see that can cause problems and often are more associated with either an anemia of some sort, a thalassemia, or hemoglobinopathy. So those are the things that can cause problems with the patient more than others that could be artifacts. Like, for example, Burr cells are usually artifact that can help happen in vitro when it's in the tube and not the body. So like it has maybe the cells shrink up a little bit in response to the anticoagulant or the EDTA component inside the tube that's used for CBC analysis. So the ones that I've pointed out here are the ones that are going to be most clinically significant with regard to poikilocytosis. So keep your eyes open and know how to recognize those. Now that we know what microcytosis is, remember they're small cells with an MCV of less than 80 femtoliters. Let's talk about when do we see these microcytes. Well, The most common time we see microcytosis or microcytic red cells or microcytes, all of those words can be used in this capacity, we see them most commonly in iron deficiency. That is the most common. We may see them in thalassemias. Remember, thalassemias are those quantitative hemoglobin disorders, so impaired hemoglobin production. Sideroblastic anemia, which is where we have plenty of iron to use, but we can't use the iron appropriately, and so the iron ends up accumulating in the red blood cells. So all of those situations or disease states or conditions can lead to microcytosis. And a lot of times, for example, thalassemia, specifically beta thalassemia, which is a thalassemia that affects the beta globin chains, is really at first glance indifferential. You cannot differentiate it between iron deficiency and the beta thalassemia. So a lot of times we have to do continued testing to determine whether or not a condition meets the criteria for diagnosis. Now, on the other hand, we have macrocytosis, big red cells with an MCV of greater than 100. We see this in megaloblastic anemia, which is anemia that is caused by B12 and folate deficiency, because remember, B12 and folate are both imperative for DNA synthesis, and DNA synthesis must occur for cell division, etc. Hemolytic anemias can also cause macrocytosis. And the reason for that, if you think about it, what happens when we have a large number of red cells destroyed? Well, our body compensates. The bone marrow starts pumping out these reticulocytes that are larger in size, and MCV measures size. So now, because we have a higher cell population of reticulocytes that have been sent out of the bone marrow to compensate for this hemolytic anemia or this hemolytic activity that's occurring against our current red blood cells, we now have an elevated MCV because of this high number of reticulocytes that have been sent out into circulation. So that can also cause macrocytosis. Most of the time, a physician can do other tests to determine the cause of the anemia. For example, if a patient has microcytic hypochromic red cells and then suspects iron deficiency anemia, he would then go on, he or she would then go on to perform other tests. They may do iron studies, they may do ferritin studies, they may do, all sorts of iron tests to see, is this problem with iron storage, iron delivery, what is it? In the event or in the case where a physician can't quite determine the cause of an anemia, a bone marrow procedure may have to be performed in order to determine the cause of the anemia if other routine lab tests are inconclusive. So right here at the iliac crest is where the bone marrow is retrieved, and they kind of drill a little hole here and then stick it down into the bone marrow and aspirate out a portion. But what are we looking for in the bone marrow? Well, let's talk about it. What things do we look for in a bone marrow smear? Well, there are a couple of things. This top picture is a bone marrow smear, and what we're looking for there is cellularity. Are there a lot of cells, or So this red area, this purple area, this is the cellular center or an area of production, red marrow. And then these white areas are fat, or sometimes you would hear it called yellow marrow. All right, so we're looking for an overall cellularity. Are there the normal amount of cells that there should be? Are there more than the normal amount? So is it hypercellular? Or might this just be like mostly fat with a few tiny little areas like an aplastic anemia, so like a lot of fat? Um, Next, after we look at the overall cellularity of the bone marrow, we are going to look at what kind of cells are present. What do the cell populations look like? Are they mostly granulocytes? Are they mostly lymphocytes? Are they varying in different degrees of maturity? Or do we have a high number of immature cells? Which, if you think about it, there are quite a few more immature cells in the bone marrow, but there shouldn't be just all immature cells. There should be varying degrees because as they're produced, they go through different processes of maturation, and then they get to a maturation pool where they finish developing before they go out into circulation. But if you're seeing 90% of 90% myeloblasts, that's not really a normal population representation. So we're going to also look at the ME ratio, which is basically the myeloid versus erythroid. So remember, myeloid cells and erythroid cells all come from that myeloprogenitor cell, but then it branches off, right? So we've got white cells that are of the myeloid line and then red cells. And there should be about 3 myeloid cells for every 1 erythroid cell. And that's because red blood cells typically have that longer 120-day lifespan, whereas myeloid cells, number one, we have to produce more than one type of white cell. We have lots of different cell populations that are white cells, and so we kind of have more production. Plus, white cells typically have a shorter lifespan than red cells because they're out there fighting infection and, you know, uh, just protecting our body from a lot of things. So sometimes they're killed off in the line of duty, whereas the erythroids just go around delivering oxygen to everybody on the front line. So 3 to 1 is, or 2.5 to 1, right around that. So between 2.5 and 3 to 1, white cells to red cells. And then we're also going to look at iron storage. You're like, iron storage? How the heck do we know iron storage? Can you see iron? Well, yes, you can. Because the long-term storage of the bone marrow is within resident macrophages called siderophages, and they are there residing in the bone marrow, just hanging out. And we can actually use a specific special dye for the bone marrow called Pearl's Prussian Blue. And that is going to show us those iron deposits that are present within the macrophages of the bone marrow. And this does not have a very good picture, but I will show you one in upcoming lectures when we get to that, okay? So these are what we're looking for in bone marrow.